Okay. Hey, everybody. My name is Alex Pond with the UNM Division of Community Behavioral Health. Welcome to today's webinar presentation for the Community and Rural Psychiatric Residency webinar series. A few announcements before we get started. Please make sure your sound is muted during the presentation. If you have any questions, please submit them in the chat or feel free to unmute if Dr. Martin opens up the floor. For those requesting a CE or certificate of completion, I'll share an evaluation link in the chat at the end of the presentation. In order to receive credit, you must attend the full presentation. If you have any questions about that, please feel free to reach out to me directly. I'll also be posting a link in the chat now for anybody who's interested in ACCME credits. And Dr. Martin, that also applies to you if you need CMEs. And I can send you that link separately as well if you'd like. So without further ado, I will now hand it over to Dr. Martin. Thank you.
All right, it's a pleasure to be presenting for the Rural webinar series today. Don't have too many attendees, but I see Lakshmi's here and just wanted to hear where you're coming from. And yeah, how'd you come to the meeting today, Lakshmi, just so I know who I'm talking to. Yeah, thank you.
Hi, I'm trying to adjust my camera, but I am from Madison, Wisconsin.
Okay, great. And are you in mental health? Yeah, what's your role?
I am, let's see. Okay. So my background is actually forensic. I work at Sandridge Secure Treatment Center, which is an institution for individuals who have been civilly committed as sexually violent persons. And I'm a part of the evaluation unit.
Okay, great. Well, thank you so much for coming today. Did you have any particular interest in this topic or previous knowledge?
Just interested in the topic.
Okay, great. Thank you so much for responding and turning on your camera.
Yeah.
So I will get started and share my screen. Okay, can everyone see this? And it's not in presenter view?
It is currently in presenter
Okay,
view.
so I'll switch again. And how about now?
Yes.
It's still there, yeah.
Oh, it's still in presenter view?
Yeah.
Oh, 1 second.
Okay.
Sorry about that. And let's try this again. How about now?
Still in presenter view, but if you right click on the there we go. That looks great.
Okay, great. Thank you so much. Okay,
Perfect.
so the talk I'll be giving today is psychiatry and physician-assisted death, which goes by many names, and we'll talk about that in a moment. So as Alex mentioned, you can get CE credits, and he will be putting the link how to do that in the chat. So a bit about me. I'm originally from Vancouver Island, Canada. Prior to becoming an MD, I worked for many years as a self-employed massage therapist and wellness educator. I studied neurobiology at UC Berkeley and City College of San Francisco. Did some volunteering with San Francisco AIDS Foundation, doing some harm reduction education and HIV STI test counseling. Did some research in neuroscience on memory and aging. And then while I was in medical school at UCSF, I actually did some research on the outcomes of that university's physician aid in dying protocol and the role of the mental health evaluations in patients who are requesting the physician aid in dying. I matched into UNM Psychiatry Residency program last year. And so I've been in Albuquerque now just over a year. When I'm not at the hospital, which isn't very often right now, I like to get outside as much as possible, and I like to sing and play music. So we'll keep going. So the objectives for today, by the end of the session, I want attendants to be able to describe the eligibility criteria and the process for patients to receive physician aid in dying. want to be familiar with some of the ethical challenges and some of the ethical arguments faced by providers who are assessing capacity in patients who are choosing physician aid in dying. And I want to do a brief review of other psychiatric interventions for alleviating suffering at the end of life. I don't have a financial arrangement related to content of this activity. And the views expressed in this presentation are mine and those of some of the researchers that I've consulted or read, and they don't represent the views and policies of UNM. So this slide has a lot of words on it, but just a few things I want to talk about before getting into a somewhat controversial topic. First of all, I just want to acknowledge the indigenous people and tribal nations, including the Tiwa Pueblo peoples and the neighboring tribal nations who have stewarded through time immemorial the lands and waterways of what is now city of Albuquerque. As a newcomer to this land, I also want to honor and respect the enduring relationship that exists between these peoples and tribal nations and this land, and commit to learning how to be a better steward of the land the city inhabits, and work toward improving disparities in health access and outcomes for the indigenous people here. Many of the foundational studies that bolster the evidence for physician-assisted dying have had a preponderance of Caucasian participants. Racial, ethnic, and religious disparities are still very present in access to palliative care and physician-assisted dying, both due to structural inequities and due to mistrust by populations who've experienced harm by medicine. Ethnic minorities have suffered and continue to suffer much harm through the institutions of Western medicine, and the structural violence must be addressed in concrete ways to ensure that physician-assisted dying is practiced ethically and equitably. If someone who is close to you is nearing the end of their lives right now, and this material is challenging to engage with, feel free to turn off your cameras, take this time for yourself. And as we go along, I do want to encourage discussion and have people bring up some of their viewpoints and questions. So assume positive and curious intent, as various viewpoints, cultural and religious frameworks may be raised during the discussion. So to get into the terminology, this practice had a number of names and people refer to it as a number of things. I think what's starting to shake out as being the most common is either physician aid in dying or physician assisted death, which is PAD. I'll refer to it as that throughout the presentation. Also known as medical aid in dying, and then also known as death with dignity, which is the name of the legislation that was first passed in Oregon. Terms that we're not using are euthanasia, not using physician-assisted suicide or mercy killing. So just a little bit about the suicide term. So factually, legally, and medically speaking, it's inaccurate to equate medical aid in dying with assisted suicide. So the Oregon, Washington, Vermont, California, and various other states' laws emphasize that, quote, actions taken in accordance with the act shall not for any purpose constitute suicide, assisted suicide, mercy killing, or homicide under the law. This distinction is because a person who seeks medical aid in dying already has a terminal prognosis of 6 months or less to live. They're not choosing to die, a disease is taking their life. They're choosing not to prolong a difficult and painful dying process. So assisting a suicide, which is a different thing, remains a felony in states where the physician aid in dying is authorized. According to the American Psychological Association, medical aid in dying and suicide have very profound psychological differences. So where we're at with the legislation in the US right now, there's 10 states and Washington, DC that have passed laws that allow physician aid in dying. So about 23% of the US population has access to aid in dying. And New Mexico is actually the most recent state to pass any legislation in 2021. Most of these legislations are fairly similar in what the eligibility criteria and what the process are, but there are some little differences, and I'll talk about that in a bit. The legislations have various names, such as Death with Dignity, End of Life Options Act, in Hawaii, Our Care, Our Choice. So as I'm presenting from New Mexico, just wanted to get a little bit into this legislation that was passed here last year. So this is the Elizabeth Whitefield End of Life Options Act. Just a snapshot of that legislation. This was passed on April 8th, 2021, named after Elizabeth Whitefield, who was a distinguished and trailblazing member of the New Mexico legal community, who in her later years, after terminal cancer diagnosis, became a fierce public advocate for dignity in dying. And so she died in 2018. So this is one of the more important things to kind of internalize from this, is just knowing what the eligibility criteria are to be able to access this sort of intervention. So an individual must meet all 4 of these criteria. You must be an adult, age 18 or older, terminally ill with a prognosis of 6 months or less to live, mentally capable of making their own healthcare decisions, and I'll talk about what that means, and able to self-ingest the medication. And the word ingest there is important. So these criteria are same across all states. They might be worded a little bit differently, but these are what we're using in the US. Of note, in some of the other countries where this is available, there's the 3rd criteria is different, and they talk more about interminable suffering versus just being terminally ill. So the suffering is key there. So the process looks pretty similar among states. All of them require at least 2 physicians to participate. There's an attending physician who establishes the less than 6-month prognosis initially. They'll take a first verbal request, wait at least 15 days, take a second verbal request to make sure the patient is still consistent in their choice, and then accept a written request from the patient. They'll also write the prescription for the aid in dying medications and file a report with the local Department of Public Health. The second physician is called the consulting physician. They're required to confirm the diagnosis, the less than 6-month prognosis, and the mental capacity of the patient. Now, in some places, there's a requirement for a mental health capacity evaluation. The state of Hawaii requires this, and my former institution where I was at med school, UCSF, also has this required for everyone. And these can be performed by a psychiatrist, a licensed clinical psychologist, NP, or a licensed clinical social worker. So just to talk a little bit about decisional capacity, as you, Lakshmi, who are here, you're in forensics, you probably have a good sense of what this means. But people use this term sometimes incorrectly as equivalent to competency, but capacity pertains to one specific decision. And a person may have capacity for one decision, but not another. So I'm sorry to pick on you, but I wonder if you are able to kind of talk about what some of the elements of decisional capacity are.
So it's been ages since I have worked in that field. I work, currently my area is risk assessment.
Okay.
It's been, I think, over 10 years since I've worked in the area of competency. But the competency, the thing is, it's more statutory. So there is a sense of guidance as to what type of criteria the person has to meet. So I do know that it's not the same as competency. Somebody perhaps may be able to make a decision, like you said, but might not be competent, right? Because they don't hit those criteria.
Right. And competency is a little bit more of a global sort of thing versus a specific decision. So it's like competency to stand trial is often the time that we hear it. It's more in the legal context, whereas capacity is more in medical decision making.
Right.
So just to highlight some of the elements of decisional capacity as a review for possibly some of the people here who will watch this on recording. The capacity means an individual's ability to understand, appreciate the nature and consequences of proposed healthcare, including reasoning about it, significant benefits, risks, and alternatives to proposed healthcare, and to make and communicate informed healthcare decision. So those 4 underlying things: understand, appreciate, reasoning, and communicate are the fundamental elements of decisional capacity. So just to get into what those mean exactly. So the understanding part is to grasp the fundamental meaning of the information communicated. And I can talk about that next, sort of what questions you'd ask to get to the heart of that. Appreciate is acknowledge the medical condition and the likely consequences of various treatment options. And the reasoning is being able to engage in a rational process of manipulating the relevant information. This one is, people have different ways of reasoning and they may come to a different conclusion than you, but if you're able to see what their process is and that it makes sense for them and their values, then they can still be considered to have that reasoning element. And then the communication is expressing a clear choice of treatment. It doesn't necessarily have to be verbal. That's in general, not specifically with this legislation, because you need 2 verbal requests. And they need to remain consistent in this decision over time, not going back and forth. So the framework for determining decisional capacity was pretty well developed by Applebaum and Grisso. This slide has a lot of words on it, but this, in my references, you'll be able to see this paper that has a really great framework for what questions to ask to be able to make sure that people have each of these elements. So just as a sort of quick overview, the understanding portion, you could ask things like, what is your present medical condition? What is the treatment that's being recommended for you? What do you and your doctor think might happen to you if you decide to accept the recommended treatment? So it's sort of just an overview, make sure they can explain in their own words what the medical condition is, what's been proposed, that sort of thing. The appreciation aspect, questions you can ask is, what do you believe is wrong with your health right now? Do you believe that you need treatment? What do you believe will happen if you're not treated? And this, you can imagine somebody who is maybe in a manic episode or psychotic episode, perhaps they may lose this ability because they don't even believe that they have a medical condition, or they have a distorted perception of what it means. Reasoning, the ability to engage in a rational process, you could ask, how did you decide to accept or reject the recommended treatment? So just, hearing what kind of drove their decision and how they came to it. What makes the one option better than another option? And then the communication aspect, you could ask, have you decided whether to follow your doctor's recommendation for treatment? Or can you tell me what the decision is? And if not able, then ask what's making it hard for you to decide. So yeah, often people will lose this element if they start to vacillate over talking about the decision in a couple different sessions. Any questions before I move on from this? Because this is a big topic, and definitely lots goes into actually assessing the capacity.
So one question I have is that, so I'm looking at the questions for clinical assessment. When the physician asks the patient these questions, how subjective is the physician's opinion? Should the patient worry that, this physician does not like the answers I'm giving, maybe because he or she has some bias against the procedure, but how, because I'm looking at the questions and they seem very reasonable. But is there any structured way, criteria to assess the answers the patient is giving?
Yeah, and I think that's a great question, because there is for sure an element of subjectivity to how you interpret it, or you may have bias against what's being offered to the patient. I think everybody does to some extent, but it's really, this is not really about whether they are going to get the proposed treatment or not. This is about whether they can make that decision for themselves. So even if you personally don't think that it's the best option, hopefully you can have some amount of objectivity as you're doing this to say, okay, they've met all of these criteria, they do have the capacity now to make that decision, even if I don't necessarily agree with it. So I don't know if that totally answers your question, because I've thought about that too. You can always interpret it a little bit differently, but if they can answer these questions in a way that seems pretty coherent and consistent, they probably have capacity, even if you don't agree with their decision. And especially with the reasoning part, because that's really like values based. Somebody might have a lot of different values than you, but if it's consistent, if their reasoning process is consistent with their values, then you'd say that they do have the ability to reason about it. And just to just as a reminder, having a mental health condition doesn't necessarily preclude you from having capacity. Having psychotic disorder such as schizophrenia or having bipolar disorder doesn't necessarily preclude you unless, some of the symptoms of that are in the way of you making or being determined to have capacity.
So another quick question. So is this the stage where you indicated that there could be a second person? This is the stage?
Yeah, so actually each person along the way, so the first attending physician, typically the one that the patient asks for physician aid in dying, will see that they have capacity or not. So they should be doing this as well. And I think having the second person, which is required also, is sort of a way to make sure that we're ensuring some sort of objectivity, maybe some like inter-rater reliability about the person's capacity. Yeah, so both people will do so. And if the first person doesn't think they have capacity, then the patient doesn't move on. They don't get the medication. There are some instances where people's capacity is impaired because of maybe they have an acute infection and they're delirious right now, and they're asking for this medication. But if you treat the delirium, treat the infection, they kind of regain themselves, then they could have capacity afterwards. Or same with being in a manic episode or an acute psychosis. After the person is stabilized, they may then retain their capacity or regain their capacity. And then they kind of have to go through the process from the beginning. And so in places where there is a required mental health evaluation for people who are doing this, such as in Hawaii and at different institutions, even in states where it's not required, the role of that person is to determine whether their current state of mental health is impairing their decisional capacity. This mental health consultation is not tasked by the law with evaluating if the patient is depressed. If you can imagine, almost all patients at the end of their lives have some component of depression. That's understood. We're not trying to see if they're depressed, but whether their depression or their anxiety is, impairing their decisional capacity to come to this decision. Another role is to educate about alternatives to physician aid in dying, including hospice, palliative, and comfort care, and options of hastening death by stopping other life-sustaining treatments. So making sure people are aware of all of the options. And so the question of how are the medications administered? And I mentioned that word ingest is important because it has to be gone through the GI tract, actually. And the person has to be able to have enough physical ability to actually get it somehow into their GI tract. So you can imagine in some neurodegenerative diseases, people who are losing the ability to move their arms to actually pick something up, that would then be impaired and they wouldn't be able to take it. Or somebody who's lost their ability to swallow because of an advanced cancer, or somebody who doesn't have enough of a GI tract to actually absorb the medications, they would not have the ability to do this. And so there are some ways that people have gotten around this, which are pretty interesting. If people are not able to swallow, or people are not able to get it through their mouth into the GI tract, you can use gastric tubes or jejunal tubes. Or someone who otherwise has opted to stop all life-saving treatments might even get a PEG tube put into their stomach to be able to take the medications so that they can alleviate suffering and die sooner. Also, you can administer rectally if you're able to move enough and have enough coordination to do so. You can place the medications, which actually are quite a high volume of medications, and put them into a sort of enema or syringe that goes in the rectum. Any questions or thoughts about that? Okay. Yeah, so the legislation does not allow people to use lethal injection. Doctors cannot be doing this. Family members cannot be doing this. Family members may help you mix the medications in a form that you're able to do it. But you actually have to administer it yourself if you're going to go through with this. And so people often think that, the doctor who prescribes the medication should be there for the death, but that is not the case. Nobody has to be there after the medication is prescribed, nobody from the medical field. And often, it's preferred by the patient and their family members that they are doing their thing in their own way. And so this is giving them that autonomy. So the regulations and legislation mostly stop after the patient has qualified and the prescription is written. There's not much in the legislations about what has to happen next, other than filing a report with the Department of Public Health. But you can imagine that for the attending physician and the whole team who's been involved, ceasing to follow and care for the patient and their family members after the prescription is written is not necessarily good medical practice. I think it's probably good to follow up and see how things went with the family member if they're in a place to speak with you about it, and see if they need any extra support, as it can be a trying time. So just a few quick points on how the legislation varies by state. So the requirement for 2 or 3 providers, the third being that mental health evaluator. The length of wait time can range from 15 to 20 days across different states. And then the time for the written request to wait before you can submit that also varies. And then the language around taking versus ingesting are different. So I can't really think of some of the instances of how take has been used differently than ingest, but I think people could get really creative if there's a lot of different possibilities. If you're not able to actually ingest it through your GI tract, maybe there's a way that somebody could insufflate it, or maybe there's a way. I think people are starting to get creative, and they've made some different devices for people who are not able to do that. And then what are the clinician's duties if you're at a facility who has decided that they are not going to provide this service? That varies. And then, what are your duties when a certain clinician opts out? Like, so say you don't agree with this practice, but your patient's asking for it. Do you have duty to refer them somewhere else or not? In some states, you don't have that duty. In some states, you do. So this is just a little quick slide of some of the research I did at UCSF to sort of highlight like what we saw. And this was a pretty small sample size. It was a convenient sample. Patients who were known to the palliative care department and to the consult liaison psychiatry department who had been requesting physician aid in dying. So, this was a retrospective chart review. Of 42 patients who asked, 38 at the beginning had the capacity. And then, as we went along through the process, some people would lose capacity because of, progression of illness. Maybe they became delirious with a secondary infection. There was one person I can remember who had ALS and who very much had the mental capacity still, but they lost the ability to verbalize and they lost the ability to write as they're going through this process. So you can imagine this is somewhat of a barrier for somebody who really is, is suffering, but now they've lost capacity because of the specific language. So I thought that was interesting to talk about. Of those who were actually prescribed, 29 were prescribed, only 16 ingested it. So, often people who are opponents of this practice, they think that, once people can request this, everyone's just going to be dying and taking this. But a lot of people just want to have this in their back pocket as an escape route if things get too bad. And they want to see what happens if they just let the course go. But just to have that, to know that if things do get too bad, they can have a way out. So that was interesting to see as well. And one of the main outcomes that we were looking at is, did this mental health assessment actually capture people who were getting prescribed the medication, who maybe did not have proper capacity because of a mental health condition? And of the 38 that initially had capacity and underwent the mental health assessment, only 2 were deemed ineligible. And one of those people, it was because they had a prior suicidality years before. And so that was sort of based on the standardized protocol for the mental health assessment at that institution, that was one of the disqualifiers. And then the other person, I am not remembering why they were deemed ineligible. Any questions on this?
So I'm saying that the number is not that high, right? So the prevalence of people seeking this, so ultimately 16 used to actually follow through for about over a period of 4 years. That's not as high as I thought it would be.
Right. And, the legislation was passed in California in 2016, so it was pretty new. I think there's probably been an increase in the number of people requesting. But if you think about it, the eligibility criteria actually screens a lot of people out. You have to have that 6-month prognosis. You have to, have the ability to ingest. So a lot of people, by the time they get to that 6-month prognosis, they're losing capacity in a number of ways, and they're losing the ability to ingest too. So already it's sort of a high bar for people who may even enter the process. But I do think the number, in each state that gets the legislation, there's sort of a trial period. A lot of institutions and providers are figuring out whether they want to provide this or not. And it sort of takes some time to warm up. So I do think it has increased, but of those who have the capacity and who are, eligible, fewer than you would think actually get through to the point where they take the medication on their own. A lot of people do choose not to take it, but just have it as a backup. Or, a lot of people, the disease progresses really quickly in that time, because if you can imagine, the process from the first time you request to the time you get prescribed is 20 days, in the longest situations, 15 days in the shortest in other states. And, when you're at 6 months to live, disease can take a hold pretty quickly. So a lot of people do die naturally, even after they've gone through the process. And just a few notes on what medications are being used. So right now there's no law specifying which medications to use, which is really interesting because there's usually so much legislation about this sort of stuff, and FDA approved treatments, but this isn't a treatment. This is death. So we don't have the same sort of protocols for approval, because it's not really a treatment. So yeah, we are not really great at figuring out how to make people die in ways that are comfortable and do not prolong their suffering. In veterinary medicine, that's very common, but as you can imagine, it's difficult to study this sort of thing in humans in a way that's really ethical. So the aid in dying medications are left to the prescriber, presumably subject to the same standard of care that applies to all practices in medicine. So using your best clinical judgment. And there's definitely some data on what to use, but it's very difficult to conduct these studies. And there's some access issues to different medications that I'll talk about in a minute as well. So if you are wanting to end somebody's life in a way that is comfortable and you can guarantee that they will actually pass after taking the medications, you want to be able to stop their heart, induce a coma, reduce pain, so analgesia, and induce respiratory depression or cessation. So those are the 4 things that you want to be able to do reliably. So just a little bit of talk about lethal medications. Initially, when people were starting to do this, they're using barbiturates, secobarbital, pentobarbital. And then as those medications, which were actually quite cheap and accessible comparatively, became less available, and I'll talk about that in a minute, we've had to come up with some cocktails of medications to reliably achieve death in a comfortable way. And if you're familiar with some of the dosing of these medications when they're used therapeutically, you can see that these are extremely high doses of all of these medications. Often taking this large of a cocktail will make most folks nauseous. So you can pre-medicate with metoclopramide or Haldol or Zofran beforehand to make sure that you're able to keep it down and not vomit it up. So that's often part of the protocol, is to make sure that you have enough anti-nausea meds to keep that down. And there's no sort of consensus on like the timing of these different medications. Some people will argue that you have to take these in a certain order to make sure that because of the onset of the medication, that you're stopping the heart, that's the digoxin, at the right time. But other evidence suggests that it doesn't really matter as long as the dosing is right. And then just briefly a bit about why the medications that were so cheap became unavailable. As you can see, secobarbital was being used initially, and that reliably brought people to death in a comfortable way. But it became, there was a shortage in the US after 2011, the pharmaceutical company that made it, Lundbeck, they made a decision to stop distributing the drug to prisons in US states currently carrying out the death penalty by lethal injection. So because it was being used in this other way, it became extremely unavailable and expensive. Initially, it was about $500 for a sufficient lethal dose of the drug, but by 2016, prices had inflated to upwards of $25,000. And so, commercial manufacturers haven't taken necessary steps to ensure access, despite the supposed design of distribution controls to provide the drug for legitimate medical purposes. There's an advocate group called Compassion and Choices, who are Right to Die advocacy group. They've lobbied the manufacturer Acorn, who acquired pentobarbital from Lundbeck, to reconsider distribution for physician aid in dying, but so far to no available. So we are left in this position where we have to use these cocktails and have specific pharmacies, compounding pharmacies, participate and do the compounding of it, which that is another barrier for people being able to access this. Not all pharmacies are willing to make this available. A little bit about what has been going on at the UNM hospital with this since the legislation was passed last year. So far in the hospital, the statute has been written. The standard protocol for how patients will move through it is still in the draft stages. Most of the patients who've been requesting it so far have been referred to private hospices rather than at the UNM hospital. No patients have gone through the entire process at UNM hospital. This fact might be outdated now. As of the last few weeks, there may have been a patient who's gone through. I will need to check that. So far, only one of the patient who was requested at UNM has had a psychiatric evaluation based on the assessment of the attending physician. And the statute at our hospital only allows psychiatrists, CPs and NPs, no LCSWs and no resident psychiatrists. So I, as a resident, will not be doing these capacity assessments and mental health evaluations. So far, there's no standardized psychiatric protocol for determining capacity at our institution. And then just thinking about different departments, which at other institutions in other states are heavily involved with supplying these. Both the palliative care department and the oncology department have currently opted out of offering physician aid in dying. So there's a few champions at the UNM hospital right now. So if anyone from UNM joins the meeting or sees this on YouTube and you're interested in how this is being rolled out and who's supportive, you can reach out to these individuals. A number of other hospitals in the area have opted out of providing this as well. So it is definitely limiting who is able to access this and where. And often it is in these private boutique hospice settings that people are having to go and access this so far. Most of the nearly 100 cases in New Mexico of patients who've requested, they've all been at the hospice organizations. So ultimately, it's probably going to be primary care providers who will be the attending physicians who prescribe the medication. And so I think it's really important to kind of get the word out and get the education out about how this works and have people decide whether they're opting in and out and know what resources are available to their patients who are asking for it. So this, as we're coming up with a sort of standardized psychiatric assessment so that we make sure that as people are being assessed, there's sort of an inter-rater reliability. This is an example of what we were doing at UCSF. So full medical and medication history, psychiatric history, including substance use, family history, make sure they have decisional capacity based on what we talked about before, and then sort of their current mental status. So, doing all kind of like rating scales for mood, psychotic disorders, anxiety, and then, really being able to track how those symptoms may have changed for people over time. Also want to hear what their narrative is, like have them tell a story about how they came to seek out physician aid in dying, what they knew about it before, if there's any like coercion, what family members are thinking, are they in conflict with anybody in their life about using this? That could give a sense of whether there's, maybe some undue pressure, or maybe this, some relationship issues that could be behind why they're choosing this, which, while again, it would be a subjective decision whether they had capacity or not, can give more of a sense of why they came to that decision. And then being able to give them an accurate diagnosis and, comment on their cognitive status and, see if perhaps any medications that they're taking currently are, impacting their decisional capacity. And then make sure that the patient's understanding that this assessment is not a psychiatric treatment, but that if the mental health consultant can thinks they need it, they can recommend treatment. The mental health consultant will not be the treating clinician. And then a report of all this should be made in the EMR. Any thoughts about what would be essential elements in a standardized psychiatric assessment, or anything on here that seems strange?
So why is a family history relevant here?
I think it's an important part of any like full mental health assessment. If you were to find out somebody had a family history of depression or suicide, or bipolar or something, that wouldn't necessarily exclude them. But if this patient does have one of those diagnoses themselves, it just kind of gives a fuller picture. I think it's just sort of a responsible full mental health assessment, but I don't think that element would necessarily exclude somebody. The narrative component, I think, is really important too, because somebody may say, yeah, as soon as I heard that this was a thing in the 90s when Oregon passed this, I knew that's something that I would opt for if I were to get a terminal illness. And that would sort of show like they have been very consistent in this being a value, even when they didn't have a terminal illness. And, you can see then that they're not suicidal. This is something that they've always valued as being, a way to approach illness and death. And so I think that's important too, just kind of like what have they thought about this all along versus just now that they have a terminal illness. And so now I want to get into sort of the ethical considerations that we as mental health providers have to think about when we are deciding whether we want to be involved in doing this or not. I think one of the big things that comes to mind is, aren't psychiatrists and mental health professionals in general supposed to be against suicide? Like, how can you participate in this? And I will make a reminder, this isn't suicide. And so it's a different thing, but, it's definitely something to consider in your own practice, whether, you want to be involved with somebody who is choosing death when the majority of your practice is encouraging people to move away from that sort of decision. But there are different flavors to it, of course. So it's one thing to consider. The other thing is, if somebody came to you as a mental health provider and they are wanting physician aid in dying, and do you think you'd be able to reliably determine if their capacity is affected by their mental health status or not? And it's actually a difficult question. Most people at the end of their life do have some amount of depression, and depending how severe it is, it may be apparent that they are, it is their mental health issue, but in a lot of people, it's probably not that apparent whether this is something that existed before. There was a survey of Oregon psychiatrists kind of back in the 90s when this was being rolled out, and only about 6% of them were very confident that they could, reliably decide whether somebody had, somebody's mental health was not impacting their capacity. 43% were somewhat confident and 51% were not at all confident. And I think, a lot of us, as we're kind of thinking about this for the first time, probably would fit in that 51%. It's a really difficult question to ask, especially in a single consultation if you don't know this patient very well. the field of psychiatry has viewed suicidality a priori as a psychopathological issue. Mental health professionals have neither had experience in determining specific competence or capacity to consent to assisted suicide or assisted death, nor are there developed guidelines. So it's a really difficult call to make. And another question is, well, if somebody's so depressed at the end of their life, like, why not just offer other treatments for depression? And, that is definitely an option, but, as we know, some of our standards for treating depression, such as SSRIs and therapies, often take longer than a month, longer than 2 months to start to affect people. And so these are people who don't have a lot of time for our best treatments to start to take hold. So I do think it's valuable to let patients know what those options are. And I'll get into a little bit of other options at the end, if that's the route people want to go. And so I do think it is important to do that, but it's not necessarily mutually exclusive or the only way. And so, so there are a few ethical principles that are in tension when we're thinking about this. Primarily autonomy. Most people who are asked about why they've sought this out is they feel like, their illness has taken over every aspect of their life. There's a loss of dignity. They're, not able to deal with their own bowel movements. They're not able to deal with, saliva coming out of their mouth, but they're mentally intact. Or people who are, having such slowing of thought and like intermittent confusion that, they don't feel like they're an actual living person anymore. So that autonomy is more of a sort of like dignity at the end. So that, upholding that, which is, primarily something we try to think about in medicine, that autonomy, that's in balance with the, like beneficence and non-maleficence, because we would be, potentially hastening somebody's death, even though they, are already going to die soon from from their disease. Those things are sort of in tension. And so we kind of have to think through those. When you have a psychiatric consultation, if with somebody who the attending and the consulting physician are not quite sure if their mental health status is impacting their capacity, it actually becomes an ethics consultation, which is sort of a problematic thing. Not all mental health professionals are as versed in ethics, and when we're in that position, it sort of allows us to put a little bit more of our own subjective, like moral tones and personal meanings into it, and that's not necessarily appropriate either. So this is something we're going to have to think through as this becomes more widely available. Like, how can we make sure that we're doing this in a really ethical way and in a way that is upholding our own personal values? And just as a sort of thought, this is in my previous institution, in the notes that providers would write about their assessments, they would put this quote from Buchanan in the bottom, just to sort of show some of the ethical thought behind it. And I'll read this out because I think this is kind of interesting. So in assessing capacity in general, autonomy is being balanced against the best interests of the patient. Accordingly, the level of capacity that is required is generally commensurate and proportional to the seriousness of what is at stake and the concordant risks and benefits. And so we try to use a balancing approach, balancing patient autonomy and well-being referring to the risks and benefits, or the risk-benefit ratio of what is proposed. Relevant to physician aid in dying, the benefit-risk ratio is relatively equivalent, as death is both the benefit and the risk, with or without life-ending medications. Therefore, reducing the level of capacity required and increasing the margin of error in performing such assessments. So this is sort of a way of protecting yourself if you've determined that somebody has capacity, because if you think about it, that risk-benefit ratio has sort of changed from most maybe risky treatments people have, because the risk and the benefit are the same. So the margin of error can be much greater, and people don't necessarily have to have the same level of capacity that they would for really intrusive intervention that somebody might have at the end of their life. Any thoughts or questions on this before I move on? And just as a sort of thought exercise, there are patients who might be determined to have impaired judgment who up until their mental health evaluation might otherwise be eligible for physician-aided dying. And so just kind of a few things to think about here. So you can imagine somebody who's a severely depressed patient who is, they've made it through the first evaluation with an attending, the next evaluation with a consulting, but they get referred to a psychiatrist, perhaps because the previous providers could tell they're depressed. But then, it turns out that they are having delusions of deserving punishment or death as part of their, depressive disorder with psychotic features. And so then that would sort of make me think, yeah, they don't have capacity. Their depression is in the way of them actually making a good decision about this. A patient with advanced dementia who can't recognize the impact of their behavior on others. So, there are definitely some patients with dementia who can, at certain times appear very, with it and have good cognitions. And so they would make it to the mental health assessment. But then, as we're really drilling down into how they think about the treatment or the intervention, you can tell they don't really know how this is going to impact people around them. And that's part of the reasoning process and part of the appreciation of, the decisional capacity. And then you can have somebody who's, chronically hypomanic, pretty high functioning in lots of ways, but then recently has sort of, gotten worse, maybe as a result of their illness, maybe not, and they're more impulsive and they're not able to, sit down and have that conversation about the consequences of what will happen. And then you could think of somebody who's addicted to multiple drugs, who's been impaired enough in recent years by their, addiction issues, so they're unable to make other important life decisions. Decision-making process gets interrupted in addiction. So that might come out in a mental health capacity evaluation. And very controversial topic, but something that is now being practiced in Netherlands, Belgium, and Canada. The question of should psychiatric patients be eligible for physician-aided dying? As the reason for it, their psychiatric illness causing so much suffering that they should be eligible to ask to end their lives with the help of a physician. And so this is a very difficult topic to kind of wrap our heads around, and it kind of brings into question, like there's this concept called total pain that was coined by Dame Cicely Saunders. She's the founder of the modern hospice movement, and recognizing that there's pain and suffering has all of these psychological, social, spiritual, and physical components that all interact on and enhance each other. And so, at the end of life, or in a situation such as a severe mental illness, thinking about how all of these things impact each other, and thinking about how legislation is worded in some of these other countries, being rather than it just being a terminal illness, it's unbearable suffering. We think about the argument of, is mental suffering as bad as physical suffering? And, I think it's definitely, some people could argue, yes, it is, and maybe sometimes even worse. So if you can imagine, there are often people with severe mental illness who are engaged in self-harming behaviors, and they will tell you that they prefer physical pain to the mental pain that they're having. And so that's, something to consider for thinking about this. Only have a couple minutes left, so I'm not going to necessarily get into all of these arguments, but there's a lot of literature starting to come out about this and just sort of ethical ways of thinking through this question. I imagine it will be a very long time before this is available in the United States, though. So just something to consider. And then, as I mentioned, part of the role of the mental health consultant, if they are consulted about this, is to make sure people know about alternative options to receiving medications, such as, continuing treatment as usual. They could forego or cease their treatment, can voluntarily stop eating and drinking, the acronym that is VSED, and that's something that, if somebody is like palliative care is consulted with somebody, they can recommend, well, if you are trying to die right now, but don't want to necessarily do something active, you can passively just stop eating and drink. And, it's okay to recommend that to somebody if this is what they're wanting to, without, getting in legal trouble. Palliative sedation is sort of the idea of like inducing coma at the end of life, so somebody can just go to sleep and let their illness take over. And then, a sort of new field of palliative psychiatry. And I'll talk about some of those interventions now. So psychiatry as a profession, if you can think about it, is palliative in nature. We don't do a lot of like curing. There's a lot of just, relieving symptom burden, making life easier for people, trying to keep people more comfortable. But in this context, palliative psychiatry, meaning, in the context of end of life care, what sort of interventions do we have available, how effective they are. And this is sort of there's a lot of new interventions coming out in this field. So there's some evidence so far. Rather than using SSRIs, which I mentioned have take a long time to take full effect, or other lengthier psychotherapies, there's some other things that we can do that have rapid effect. So ketamine therapy is showing to have really rapid benefit in people with depression at end of life. Psychostimulants such as Ritalin and Adderall can be a way to get people more energy and feel like they're more engaged with their life, and they it's pretty much immediate. Not necessarily a cure, but energy is one of the things people start to lack at the end of their lives, and so that's one way, and their focus. And then electroconvulsive therapy actually has some of the best evidence in geriatric populations and people at the end of life as a rapid way of reducing depressive symptoms, sometimes within a matter of weeks. And then there are a few focused type of psychotherapy, such as meaning-centered psychotherapy. This is based on some of the works of Viktor Frankl. Treatment seeks to bolster meaning and spiritual well-being. And so then treating anxiety at the end of life, again, ketamine has some evidence for doing so. Hypnotherapy has some minor evidence for reducing some anxiety symptoms. And then concreteness training is another psychotherapy that is, brief and allows people to identify some of their worries and kind of change some of their ruminative patterns. And then emerging evidence for psilocybin assisted psychotherapy at the end of life. And then another role of palliative psychiatry is treating delirium, which is sort of standard things we do in a hospital. Delirium being sort of a temporary state that can be reversed once a more medical issue is resolved. Any thoughts or questions on this before I go on? Just a few resources here for more information, how to access things if you have patients. These end of life options, New Mexico, that's here in the state, and then Compassion and Choices is a national advocacy organization. These are my references. If anybody wants any of these slides later, please reach out to Alex or Shayanti. And here is the evaluation link, QR code, and I think Alex will also provide that. So I will stop sharing now. Thank you so much for your attention. I really appreciate it. Any questions right now before we wrap up, or any final thoughts?
I have just a couple questions.
Sure.
First one, am I correct in my understanding that one would have to be a resident of the state to have access to this? In other words, can I go to Oregon, or am I out of luck because I live in Wisconsin? How does that work?
That's a great question. It depends on the state. Different states have different legislations about it, and different requirements for what's considered a resident of the state. And there were a number of court trials about this in the late 90s and early 2000s about people who were moving to states to get this. And so that is sort of a developing question too. But I do think for the most part, you have to be a resident. So it depends on what the state's requirements for residency are.
Oh, okay.
Yeah.
And a last question is that so the way the process works is that a person is assessed various levels, and say the person is qualified to make this decision and they are provided with the medication and then they leave the clinic with it. And then it's their call to figure out when to take it, correct?
Yeah, and so they don't leave the clinic with it. They'll have to go to a pharmacy.
Okay, I see.
Yeah, specific pharmacy and pick it up from there. And so some pharmacies have different rules about it. It has to be, delivered, by FedEx from the pharmacy to the person's house. Some pharmacies will be like, no, you can come and pick this up, or a family member can pick it up. So there's some variation in that too. But yeah, that sort of depends on the pharmacy.
So is anybody keeping tab of, is it used? And if not, I'm sure it has to be, say the person does not use it, but dies naturally. There has to be a proper way to get rid of it. Is anybody keeping tab on how to do that, or?
They absolutely should be.
Okay.
Yeah, they should be, and I think most legislations and states have some requirement for how to deal with that.
Right.
And so part of that is filing your report as a provider to the Department of Public Health, and I think there's usually a standardized sort of form that you fill out that will say whether you did your due diligence to try and educate how to dispose of the medication properly. And I imagine the pharmacies also have some sort of rules around that too. Like they will not give it to you unless somebody has agreed to bring it back if it's unused. But record keeping is super important for this, especially as we're trying to get more evidence about it. And that's what's difficult is that because it's such a private thing, it's really difficult to access this information from departments of public health about individuals. And so that is also a barrier to keeping good records and having good evidence. So yeah, something to develop.
Okay, thank you.
Yeah, thank you so much for your attention. I really appreciate it. Hope everyone has a great day.
Thank you.
Thank you so much, Dr. Martin. That was a fantastic presentation. Truly appreciate you.
Yeah, thank you so much.
All right, be well.
Thank you so much,
Take care.
Dr. Martin.
Yeah, no problem. Thanks for your help, yo.
See ya.
Okay.